So, okay, today we're going to do chest pain or approach to chest pain. Chest pain is one of the common presentations in clinics and in the emergency department. Most cases of chest pain, they are non-life-threatening, specifically peptic ulcer or GERD causing chest pain or burning sensation in the chest or heartburn. Most commonly, cause of chest pain is musculoskeletal pain. However, for MCCQE and for real life patients, the calling chest pain as something non-urgent or non-life-threatening requires you to rule out the life-threatening conditions first. You can do that by taking a full detailed history, physical examination, some basic labs, which we are going to discuss what to do and what not to do. Today, we're going to discuss how we're going to approach a patient who comes with chest pain. Now, if you go to any emergency room here in Canada and you say you're having chest pain, they're going to do a quick triage on you. And the idea is to get an ECG in less than 10 minutes. ECG within 10 minutes, so that if there is any changes of myocardial infarction like ST elevation or ST depressions, it is not missed. In most emergency cases or most emergency rooms, you will get an ECG. There was a recent case in the news that a hospital, I think it was Princess Margaret Hospital here in Ontario, they kept a patient who was 44-year-old male waiting in the emergency room when he came in for chest pain and told them that he doesn't feel good. Unfortunately, he passed away. Turns out patient was having massive MI or had a massive MI and then couldn't be resuscitated once he went into arrest. Therefore, if patient comes in with chest pain, the minimum to do is an ECG and troponins, unless the history specifies exactly a non-cardiac cause. For example, patient says that they had spicy meal and they're feeling pain after the meal, or they have pain whenever they eat something spicy, and they have no risk factors for cardiac disease. You can say, okay, we will observe you for a bit, do an EKG for them, and be sure that the patient doesn't have an acute MI, and you can then follow them up in the community. But if someone has risk factors like dyslipidemia, obesity, hypertension, diabetes, strong family history of heart disease, in those cases, we would do serial ECGs and serial troponins. And nowadays, previously we said, oh, it's typical chest pain for MI, and those patients would take priority and they will get tested more thoroughly. And then atypical patients whose chest pain did not match the classic presentation of MI, they could not be investigated as thoroughly because it was atypical per se. Nowadays, we don't rely on typical versus atypical. We rely on the full history of the patient to make sure that the pain is not coming from an acute process like an MI or embolism or pneumothorax, etc. Now, for chest pain patients, the first question should be stability. Is the patient stable or unstable? If a patient was complaining of chest pain and they called the ambulance and ambulance brought them in unconscious, it is likely to be something life-threatening. Now, what would the priority be? Your ABCs: airway, breathing, circulation. Now, airway, you would look at the trachea, you would open their mouth and see if there is any signs of any debris or any falls or any injuries in the mouth, and then palpate the trachea to make sure it's midline, it's not deviated. Listen to the breath sounds, and if patient is unstable, you're unlikely to hear any breath sounds. check their blood pressure. Circulation, we don't really have much for circulation, but we can check it through pulse and blood pressure and oxygen saturation. Along with all these, we would check the patient's mental status. If a patient with chest pain comes in, they have good airway, their airway is patterned, they're talking, they're breathing spontaneously, their blood pressure is good, their oxygen levels are good, they're alert oriented. This means this is a bit reassuring, even though it still could be an MI, but it is reassuring. But if patient is not alert, that means patient needs to be treated urgently with following the ABC protocol. Now, first thing is whenever you have a patient with chest pain, your evaluation, it should start with exclusion of life-threatening diseases. Life-threatening conditions for chest pain include acute coronary syndromes, tension pneumothorax, pulmonary embolisms, especially if they're massives. These are aortic dissections, another life-threatening condition that can acutely make the patient decompensated. Pericarditis, especially if it is causing tamponade symptoms, so it's going to be life-threatening in acute, in a few minutes or possibly an hour, but it's life-threatening. The first things that we are going to do when we are evaluating is think of coronary syndrome, aortic dissection, pulmonary embolism, pneumothorax, rupture of esophagus, especially if patient is an alcoholic who has been vomiting a lot in the past few days. Borheim's rupture or esophageal rupture can occur in people who are vomiting excessively. Now, some red flags that you should be aware of is severe sudden pain. If severe sudden pain starts, this is usually not good news. Sometimes it could be the precordial catch syndrome, but that pain resolves in a minute, in less than a minute. If severe sudden pain starts and it reaches its maximum intensity in a few seconds to a minute, it is something serious. Pulmonary embolism, pneumothorax, they present with pain like that. If there is syncope, patient is dyspneic, they have chest tightness, they are sweating, they have any deficit of a neurological deficit, then it means that patient's chest pain may not just be a simple chest pain, they may also have an embolic stroke with it. If the pulses are unequal on the two sides, it could be dissection. Check blood pressure on both sides to make sure blood pressure is matching. For chest pain, remember in clinics, you would see, let's say you see 100 patients, 90 of them will have non-cardiac or non-lethal chest pains. 10 would have something that is cardiac or lethal. MCC is going to test you on those lethal conditions first that you shouldn't miss. And they're going to add a few non-lethal causes in there. During your exam, you will notice you're getting questions that are addressing both the lethal and non-lethal causes, but the lethal may have a higher proportion of showing up on your exam. Therefore, make sure you're able to differentiate chest pain that could be coronary syndrome from non-coronary or non-urgent chest pains based on the patient's clues. Since in exam, you do not have the patient sitting in front of you, you're just going to go by the step. Now, once you are with the patient who is here with chest pain, take a full detailed history, onset, location, quality, radiation, duration, triggers. These are the most important things that you should at least cover when you're taking history from the patient. When did it started, what they were doing, where the pain is. Chest pain that is typical for heart or for coronary syndromes is retrosternal and patient is unable to pinpoint it. They say it feels like someone is squeezing their heart, someone is sitting on their chest, or there is chest tightness, something like that. Location would give you idea. Quality, we already discussed. Radiation, typical MIs, they radiate to the left arm and jaw. Aortic dissection typically radiates to the back. If you have any of these radiations, then it is concerning for these conditions, and we need to do relevant investigations to rule them out. Duration of pain. If the pain starts and ends in 10 seconds. Some of you may have experienced it personally, something that we call the precordial catch syndrome or precordial catch, where a nerve is suspected to get trapped between muscles and cause a sudden sharp chest pain. And then when you breathe, it makes it worse. But after staying or not moving for a few seconds, it quickly resolves. That's precordial chest syndrome. If it is in that pattern, then you can think that, oh, it could be that thing. But chest pain of MI is going to be persistent since the start. It's not going to go away unless we intervene. For angina, pain would resolve in 5 to 10 minutes, typically less than 15 minutes. Triggers, now, if someone is feeling lower chest pain that is triggered by food, we can think that they may have a peptic ulcer. For MI, exertion, stress, large meals, these are some of the triggers that can cause the pain of myocardial infarction to start. Pleuritic features, if the pain gets better when the patient bends down, worsens with taking a deep breath, it means that the pain may be originating from the pleura. Changes with position, bending forward, making it better, maybe pericarditis or pleurisy, etc. Some associated symptoms to look for. If chest pain has shortness of breath with it, nausea, palpitations, fever, cough, shortness of breath, nausea, palpitations, sweating, these can occur in MIs along with chest pain. If there is fever and patient has pain, then we would think of infectious causes. Cough would make us think of pulmonary or specifically pneumonia before we think of other causes. However, these symptoms can occur in any of the conditions. All right, so don't just rely on one symptom in ruling out a serious condition based on just one symptom. Now, once you are done with the history for physical exam, the first thing is if patient is stable, vitals. If patient is unstable, your ABCs. ABC, airway, breathing, circulation. Address these first before you do anything else. For stable patients, check vital signs. Look for new murmurs. Sometimes MIs of the septum can cause new murmurs to show up. Look for blood pressure in both upper arms, upper limbs, and the difference in upper and lower limbs. Unequal blood pressure could indicate pathology with the aorta. Look for deficit or pulse deficits, lung asymmetry. Sometimes if you have pneumothorax, you may see the patient's one side of chest not moving or expanding with the breathe, or when they're taking a breathe in or when they're inspiring. Look for chest wall tenderness. Tenderness of the costochondral area may indicate that patient's chest pain is caused by costochondritis instead of an acute coronary syndrome. And also look for signs of heart failure, specifically basal trachels, S3, and pedal edema. Remember one thing, chest wall tenderness does not exclude acute coronary syndrome. So if you have a patient who has chest wall tenderness, do not say, oh, it is costochondritis. Just go make sure it is not acute coronary syndrome. Investigations wise, the ECG and troponin, they are to be done early. Now, high sensitivity troponin that we normally do here in Canada, this is the preferred biomarker. You can also do chest X-ray if you think pneumothorax, pneumonia, mediastinal widening, which would be seen in aortic dissections, are going to show up on it. But ECG and troponin, they are for most patients with chest pain. And we do not do just one ECG or one troponin levels. We do serial ECGs and serial troponin levels to make sure, because troponins may take 3 to 6 hours to become positive. If the first is negative, it doesn't mean that acute coronary syndrome is basically excluded. It can show up later. Now, how we manage acute coronary syndrome if we find out that the patient has acute coronary syndrome. Now, how will we know they have acute coronary syndrome? ECG changes, ST elevation, or ST depression, T inversion. These are some of the changes in ECG that you would see in STEMI and NSTEMI. STEMI will have ST elevation. If there is no ST elevation, it's NSTEMI. Troponin levels are going to go up in both STEMI and NSTEMI. Unstable angina, the pain would not get better with rest. It's going to continue beyond 15 minutes, and ECG and troponin both will be negative. So for acute coronary syndrome, STEMI, ST elevation on ECG, NSTEMI, ST depression or T inversion, these non-specific changes on ECG. For unstable angina, no ECG changes. Now, how we differentiate our unstable angina for NSTEMI from NSTEMI? Both may have no ECG changes. Troponin level is going to tell us if it's unstable angina or patient has NSTEMI. Early in the treatment for patient with acute coronary syndrome, aspirin. We normally give 325 milligram and ask the patient to chew it. It's going to be better, but chew it. Along with aspirin, if blood pressure is good, you give nitroglycerin, you give oxygen saturation is low, you give patient heparin or anticoagulation in both STEMI and NSTEMI. And STEMI patients, after heparin, they're going to be taken to the cath lab for possible PCI, or they may get a CIBG, but it depends on their condition and indications for each of them. Okay, now some patients have low risk acute chest pain. If it is not STEMI and NSTEMI or unstable angina, then we can say it is low risk acute chest pain. If patient is stable and low risk, do not do advanced cardiac testing like stress test and coronary angiography, etc. You can monitor them or follow them up in outpatient. Manage their symptoms, give them safety advice. If the pain, give them the red flags: pain starting on exertion, pain starting on heavy meals, pain starting on emotional stress, means that it may be from the heart. Come back if that happens, things like that. You need to follow them up in the outpatient, tell them to go to their family doctor, and they're going to then investigate them for other causes of the chest pain. All right, remember in clinic and in the exam, use a clinical decision pathway. Do not just go over your feelings. Oh, I feel like it's not cardiac cause. No, make sure that you are following guidelines. Guidelines is what is going to save the patient and you. Some common non-cardiac causes. I think musculoskeletal pain is the most common cause of chest pain, followed by GERD and then by other causes. GERD, which is gastroesophageal reflux disease, costochondritis. Anxiety can sometimes present with typical presentation of an acute coronary syndrome. ECG troponins would be negative. Pneumonia, musculoskeletal strain. These are some of the other causes that can cause chest pain. Pleuritic pain that is deep inside the pleura and is felt more on taking deep breaths. This would be more specific for or more pointing towards pleural or pulmonary disease. If patient has burning sensation postprandial or after eating, it reflects or it suggests or it points more towards reflux or esophageal disease versus cardiac disease. Now, how we approach a patient with chest pain? First, stabilize them. Red flags, ECG and troponin early. Do their TIMI score, heart score. Those are the scores that we use for finding out if the patient has high risk for cardiac disease or patient is low risk. And discharge once you exclude serious conditions like coronary syndrome, dissection, etc. For NCCQE1, remember, do not call chest pain atypical. There are better classification that can be done. Women, elderly patients of diabetes, they may not feel chest pain. They would come with shortness of breath or feeling unwell in general, they would say, I don't feel well. They may say I have palpitations or heart racing. Nausea is a common presentation in women with experiencing acute coronary syndrome or people with diabetes or those who are elderly, especially if they're above 75. Shortness of breath, palpitations. These are some of the other presentations that can be of acute coronary syndrome. Shortness of breath is also angina equivalent if patient has shortness of breath, and from the history and physical exam, it cannot be uh, related to their ongoing health conditions, then it is considered equivalent to angina. We will do ECG for this patient too. One thing to remember, first ECG could be normal. It doesn't mean ACS is excluded. You have to do a repeat ECG. And usually in exam, they will say serial assessments. Serial assessments is going to be your answer in most cases. Finally, chest pain, it is a symptom, not a diagnosis. Safest approach is to stabilize patient, screen for lethal causes, and do targeted testing for those lethal causes. If the patient's history matches more with the aortic dissection, get an X-ray. If it is more towards acute coronary syndrome, get ECG, troponins. You can then do more testing if needed. And for NCCQ-E1, think what is going to kill the patient right now or today. That should be the first thing that you rule out when you're doing MCQs for NCCQ-E1. And in clinical practice, it should be your mindset that I need to keep my differentials broad, but I have to make sure nothing serious is going on with the patient and rule them out first, like acute coronary syndrome. It can quickly evolve into arrhythmia and patient would collapse before you even realize it. Hope this helps. I'm going to stop the